Welcome to the third week of our teaching series. Time has flown by so quickly. This week, we'll be focusing on upper limb trauma and orthopedics, and we're very happy to have you all here with us today. Today, I am joined by Aisha Salani, who will guide you through the anatomy of the upper limb. Just to introduce Aisha, she is a third year from the University of Central Lancashire. To make the session as engaging as possible, we'll be releasing polls throughout. These are completely anonymous, so we encourage you to participate actively. If you have any questions during the session, please pop them in the chat and we'll address them at the end of the session. We'll also share a feedback form at the end, so if you complete this, you will receive a certificate of attendance and exclusive discount codes to Teach Me Surgery and pass the MRCS. The session is being recorded, so the recording and the slides will be shared on our Medall page as well as our website a couple of hours after the session, so please be sure to keep an eye out for that. As you may know, we have recently launched our very own learning portal, which is hosted on our website. Through this, you will get access to practice questions, session recordings, and revision material. As a bonus, all members will get a discount code to get 10% off the Geeky Medics anatomy flashcards, surgery flashcards, and knowledge bundle. Membership is completely free, so please be sure to head on to our website after the session to explore this. We also have an exciting opportunity for all of our attendees. 2 lucky people will win free access to the Geeky Medics surgical flashcards and the Geeky Medics OSCE stations. To enter, simply complete the Google form we send at the end of the session and enter the unique code we will provide. The more sessions you attend live, the higher your chances of winning. So be sure to stay until the end of the session and attend as many of our other sessions as well. Finally, before we begin, we'd like to thank our partners, the Royal College of Surgeons, England, Geeky Medics, the MDU, More Than Skin Deep, Medall, Teach Me Surgery, and Pass the MRCS. Without further ado, I'll now hand it over to Aisha.
Thank you so much, Rishita. Good evening, everybody. As Rishita mentioned, my name is Aisha, and today I will be going over upper limb anatomy. So without further ado, let's begin, okay? So these are our learning objectives for today. As you can see, there's a lot of objectives, but what I've done for today's session is that I've basically divided this entire session into bits: bones, muscles, neurovasculature, and some extra bits like anatomical spaces, okay? So let's start off with the bones and joints of the upper limb. So what bones make up the upper limb? Okay, we have our scapula, clavicle, humerus, radius, ulna, 8 carpal bones, 5 metacarpal bones, and 14 phalanges. So you can see all of them in the diagram here. There's your scapula, clavicle, humerus, radius, ulna, carpals, metacarpals, and phalanges. Okay. So now what we're going to do is we're going to explore the osteology of each bone individually. So starting off with the scapula, it's basically a large triangular bone that lies over the posterolateral chest wall, and it extends from rib 2 to rib 7. And one of the most prominent surface features of the scapula is the spine of scapula. And that can be noticed on the posterior part of it. So when you actually feel your back, you can actually feel the spine of the scapula. That's that very prominent structure over there. So the scapula obviously has an anterior and a posterior surface, and this spine lies on the posterior surface. It also has superior, medial, and lateral borders. And since it has these borders, it also has angles as well. So superior angle, inferior angle, lateral angle. Okay, now the spine of the scapula, it holds a lot of significance. Why is that? Because it divides our scapula into fossae, okay? Specifically the supraspinous and infraspinous fossa. Now, another thing about anatomy that you need to remember is that most of the times, everything's literally in the name. So supra, above, so supraspinous, and then you have infraspinous, below, okay? And there's other structures that's relevant as well, like the acromion, coracoid process, glenoid process, very important because and it's, it forms part of the glenoid cavity, which forms our glenohumeral joint, and we're going to go into detail into all of these, okay? We have our supraglenoid tubercle, infraglenoid tubercle, and these structures are also very important for muscle attachments. So just know that these structures exist, and we will discuss the relevance later as well. Another thing to remember in anatomy is, especially for the upper limb, you need to keep yourselves oriented. So you need to imagine a person standing upright with the palms facing forwards. And this is specifically important when we talk about the radius and the ulna, to know which one's medial and which one's lateral, because a lot of people tend to confuse that. Okay, so we have our clavicle right here. The clavicle, it has a superior and an inferior surface, and it has its anterior and posterior margins. Now, the clavicle also has its curvatures. So it has a medial curvature, it has lateral curvature. It also has these trapezoid lines, conoid tubercles, acromial facets. So these are all points of articulation or attachment with muscles. Like, for example, sternal articular surface, that's where it articulates with sternum. So again, as I mentioned, all in the name. Okay, so that's how you keep yourselves oriented. And the clavicle, one really interesting feature about it is that it is the only point of attachment between the trunk and the upper limb. So as you know, we have an axial skeleton and we have an appendicular skeleton. Your appendicular skeleton is basically your limbs, and your axial skeleton's your trunk. So the clavicle is the bone that connects your upper limb to your trunk. So very interesting feature. Okay, moving on, we have our humerus. It is the longest bone in the upper limb, and it basically makes up the entirety of your arm. So the only arm bone that you have is the humerus. Okay, and let's have a look at the different structures of the humerus. So we have the head of the humerus. Okay, that's the part that articulates with the glenoid cavity to form the glenohumeral joint. We have an anatomical neck, and we also have a surgical neck. Now, in anatomy, a neck is basically when a head articulates with the shaft. So that's what we call a neck. But the reason we have a surgical neck here is mainly two things. Firstly, this is the part of the humerus that can often get fractured. And secondly, the axillary nerve runs in this region. So in cases of fracture, there can be damage to the axillary nerve, and that is of important medical relevance, which is why we have a surgical neck in the first place. We also have our greater and lesser tubercles, which are all muscle attachment points. And we have an intertubercular groove. And as I mentioned, again, everything's in the name, intertubercular, between the tubercles. It's also called a sulcus. You can call it a groove. Okay. The shaft is basically the body. And we also have a radial groove as well. So the radial groove is like this groove here where the radial nerve runs. So when you have mid-shaft fractures of the humerus, the radial nerve tends to get injured, which can present with certain specific features. And when we're talking about the innervation of the radial nerve, we'll explore these features later. We also have our epicondyles, which are again clinically important in cases of epicondylitis. They can get inflamed, they can get affected. The capitulum, trochlea, radial fossa, coronary fossa, olecranon fossa, all of these structures are important because this part of the humerus, the distal part of the humerus, articulates with the radius and the ulna. And when we discuss the radius and the ulna, we will also discuss these points in more detail, and that's when it will all click. Okay, so before we go into that, we'll first have an overview of our shoulder joint. So it's basically a synovial ball and socket joint that allows for a wide range of movement. So as I mentioned, it's where the humeral head articulates with the glenoid cavity. Okay, now in anatomy, there's always a cost of something. Okay, in our shoulder joint, it allows for a wide range of movement, sure, but a little bit of stability can be compromised. Now, don't get me wrong, there are lots of muscles and ligaments that allow that, shoulder joint in place. You have your rotator cuff muscles and other things like that. And just so you know, the shoulder joint will be discussed later on as well. So don't worry about that. But what I'm trying to say is that because there's, you've seen that there's a lot of cases where we have shoulder dislocations. So that's because you need to remember this factor here. It does allow a wide range of movement, but there's also that stability factor that's involved. Okay, there's the glenoid labrum. That's basically this part here where the part of the joint where it articulates. It has a fibrous capsule because it's a synovial joint, and there are other ligaments involved like the glenohumeral ligaments, coracohumeral ligaments, transverse humeral ligaments, and as I mentioned, these are the ligaments that help with stability. Okay. Now, radius and ulna. So again, as I mentioned, when we're keeping ourselves oriented, keep your palms forward, okay? So the radius is lateral and the ulna is medial. And these two bones make up our forearm. So a lot of people tend to mix up these bones, okay? So remember, these bones have their own characteristic features. The radius has a round head. That's what helps you distinguish that, okay, this is the radius. The ulna has its olecranon here. So this olecranon process is what articulates with the olecranon fossa in the humerus. Okay, so again, moving on to the parts of each bone, the radius has its own head, neck, a radial tuberosity, and a radial shaft, has its own stellar process. And each of these processes have their own articulation, so that's why they're of major significance. And another thing to note is the tuberosity. Okay, you see this word a lot, tuberosity, tubercles. What are they? They're all muscle attachment points. So the reason why we have these tuberosities is because when muscles attach to this part of the bone so much, that bit of the bone essentially gets that shape from being pulled from all the muscles. So you have your radial tuberosity and you have your ulnar tuberosity. And when we move on to the muscles later on, we will see that these are all important attachment points. Okay. So again, ulna, we have our olecranon, we have the trochlear notch. Remember, we had the trochlea in the humerus. Coronoid process, we had the coronoid fossa in the humerus, ulnar tuberosity, and the stellar process of the ulna. Okay. Now, elbow joint. So, like the shoulder joint, which was simply the glenohumeral joint, our elbow joint is made up of three joints. It's the humero-ulnar, humero-radial, and the proximal radio-ulnar joints. Okay, so the elbow joint is essentially like a complex hinge joint, so it just allows for a bit of like flexion extension. But when you think of the humeroradial and the proximal radio-ulnar joints, it also allows for supination and pronation of the forearm. Okay, and again, like every other joint, stability is achieved by ligaments. So in this case, it's the medial and lateral collateral ligaments. Another important structure to note in the elbow joint is the olecranon bursa that sits right there. It sits between the olecranon of the ulna and the overlying subcutaneous tissue. And in case of olecranon bursitis, it can get inflamed. It does happen very frequently, so an important structure to be aware of. Okay. Now, carpal bones. They're basically a group of 8 bones, and these bones, each one of them are like irregularly shaped, but they all fit together perfectly like one big puzzle. Okay, and what they do essentially do is these bones articulate with the inferior articulating surface of the radius. Notice how I said radius and not ulna, and we will get to that later on when we're discussing the wrist joint. Okay, but in the carpal bones, we have a proximal row and a distal row. So proximal, closer to the radius, distal, further away from the radius. Okay, proximal row is the scaphoid, lunate, triquetrium, pisiform, and your distal row, it's the trapezium, trapezoid, capitate, and hamate. Okay, and a tip that I use, everybody uses mnemonics. There's so many mnemonics out there to remember the carpal bones. So the one that I use is to save lives, the physician helps create treatments. So I'm starting with trapezium and I'm ending with trapezoid. Okay, but there are honestly so many mnemonics out there. You can use whichever works for you. Okay, so as I mentioned, a wrist joint. The wrist joint is an ellipsoid joint which is formed by the articulation of the radius with some of the carpal bones. Why did I not say ulna? Because the radius and ulna are always together. Because the ulna is not involved in the wrist joint. Okay, the carpal bones articulate with the radius. And on this bit here, you can see that there is an articular disc of the radio-ulnar joint. So the radius and the ulna are joined together, and the disc of that joint articulates with the wrist joint. The ulna itself is not involved in the wrist joint, and this is a very important fact to remember because for some reason, examiners love to ask that question a lot. So just be aware of that. Okay, and again, stability is achieved with the help of ligaments. muscles around the wrist also contribute to the dynamic stability. So we will be discussing muscles later on as well. And the carpal bones that are involved in the wrist joint are the scaphoid, lunate, and triquetrum. The pisiform is not involved. And the pisiform itself is a very tiny P-shaped bone, essentially. So it's really small, so it's not really involved in this joint, okay? So it's scaphoid, lunate, triquetrum, along with the distal end of the radius and the articular disc of the radial ulnar joint, okay? So metacarpals and phalanges. So now our metacarpals, they are long cylindrical bones in the hand which attach to the phalanges, okay? And the phalanges are basically the bones that make up your finger. So your metacarpals, these are the bones that are found in this bit of the hand right there, as you can see, 1, 2, 3, 4, 5. So we have 5 metacarpals. And when we talk about fingers, your first metacarpal, the first finger that we ever talk about, the first metacarpal, first phalange, these are all, the first one is referring to the thumb, whereas the fifth one refers to the little finger. So first is thumb, a fifth is little finger, okay? So these metacarpals are attached to the phalanges by the metacarpophalangeal joint, or our MCP joint. A lot of places you just see MCP joint, so you know that that's referring to a metacarpophalangeal joint, okay? Now we have 14 phalanges. Now you think, okay, why isn't it, why such a weird number, right? Because our thumb has a proximal and a distal phalange, whereas the other fingers have 3, a proximal, a middle, and a distal phalange. So your thumb essentially has 2 phalanges connected by one joint, which is the interphalangeal joint, whereas the other bones, the other fingers, which are connected by 2 joints. So you have a proximal interphalangeal joint and a distal interphalangeal joint. Proximal closer, distal further away. Okay, I hope I'm making sense so far. We are going to stop here for a bit, okay, and we will do a one poll question. So I have a question related to the osteology. So yeah, let's see how well we know our osteology. So yeah, there we go.
So 70% have said radial nerve.
Okay, thank you, Rishita. So patient presents with wrist drop following a mid-shaft humerus fracture. Which nerve is most likely injured? So I can see that most of the people chose a radial nerve. A few of you all have chosen the axillary nerve as well, and I can understand why this can be a matter of this, can confuse you, but let's remember, okay? I'm going to go back to my slide on the humerus to explain this to you properly, okay? Now this is mid-shaft humerus. This is your shaft, mid-shaft humerus. This is where your radial groove is. This is where your radial nerve is, okay? You also have this bit here, that's the surgical neck. This is where your axillary nerve is. But in this case, the shaft of the humerus is fractured. And in this case, the radial nerve is affected because the radial nerve is responsible for it innervates these muscles. So because these muscles aren't functioning well, your wrist essentially just drops like this. So that's what we call a wrist drop. And now we're going to be moving on to the muscles. So I will explain to you the innervation of these muscles. Okay. So thank you, Rishta. Let's carry on with the muscles of the upper limb. Okay. So what I've divided, how I've divided the muscles is that I've basically given a brief summary of each of the muscles here, okay? And hopefully that makes things easier because I do know that people tend to struggle a lot with the muscles. So let's start off with our anterior arm muscles, okay? So your anterior arm has your coracobrachialis, brachialis, and biceps brachii, okay? These 3 muscles. So again, a lot of the times, muscles, their names are essentially either made of their origin and insertion, their attachment points, or it's made up of their function. Then, it's named according to the function. So basically, we have our coracobrachialis, coracoid process. So it starts off at the coracoid process, and it inserts at the middle 1/3 of the medial surface of the humerus. So this is our coracobrachialis, coracoid process, and medial surface of the humerus. Okay. And another thing to note is that all muscles of the anterior arm are innervated by the musculocutaneous nerve. Yes, there's a bit of an exception here in the brachialis, but most of it is still musculocutaneous. Okay. So innervations through musculocutaneous. So if you group everything, it's easier to understand. Okay. And another thing about muscles is that you need to remember that if a muscle crosses a joint, it essentially helps with moving that joint. Okay. Now let's think of our anterior arm muscles. Okay. Let's just think of position. Okay. This is anatomy. Your body has the anatomy. Use your body to study anatomy. Okay. So you have coracobrachialis, brachialis, and biceps. Where are these muscles? They're all here. Now, muscles, they often do this kind of a teamwork situation. So when one group of muscles contract, the other relaxes. So your anterior arm, when they contract, think about it. These muscles, if they contract, I'm pulling my arm like this. And so it's essentially producing a flexion movement. And at the same time, my posterior arm muscles are relaxed. So basically, these anterior arm muscles are responsible for flexion. So think about it. Anterior arm muscles, they are responsible for flexion, innervated by musculocutaneous nerve. You already know the innervation and the function of the anterior arm muscles. It's that simple, guys. We're going to keep it simple, okay? So when we think about the function, the coracobrachialis, yes, it does a bit of adduction and it flexes the arm at the glenohumeral joint, but the main function is flexion. Do know that when it comes to muscles and all, a lot of the time there are muscles that have multiple functions, but they also have a primary function as well. Okay. Moving on, we have our brachialis. The brachialis starts off at the anterior aspect of the humerus, and it inserts at the ulnar tuberosity. Okay. So we have our brachialis here. Okay. And it starts off at the anterior aspect here and inserts on the ulnar tuberosity. See, I told you, ulnar tuberosity, muscle attachment point. Okay. Now, it's mostly innervated by the musculocutaneous nerve, but a small lateral part of this muscle is supplied by the radial nerve as well, but its major function is to flex. Okay. And now we have our biceps. I think biceps are the classic muscles. A lot of people know about them, but it's still, good to have a review of it. So now the reason we call it biceps is because bi as in two. So it has two heads, but the reason it's all classified as one muscle is because these two heads converge into a single tendon and attach on one point. So the short head, basically, it starts off at the coracoid process, whereas the long head starts off at the supraglenoid tubercle of the scapula. And both of them insert onto the radial tuberosity. So important point again, okay? And again, it's innervated by the musculocutaneous nerve. And obviously, it's not just one nerve going through the muscle. It has these segmental branches that pass on to each belly, which, helps with the proper innervation. And again, it flexes the forearm at the elbow joint. Think of it, contracts, flexes, okay? And when people tend to flex their biceps, they're flexing it, and that's the biceps in action. It's also responsible for a bit of supination, okay? So now, moving on to the posterior arm, the triceps brachii, and this is the only muscle in the posterior arm, by the way, so life is easy, okay? So when we think about our anterior muscles, when they were contracting, we were flexing our hand. Now these posterior arm muscles, when they contract, we are going to extend our arm. So when these posterior arm muscles are contracting, these anterior ones are relaxing. So, antagonistic function. So again, triceps brachii, because tri means three. So it has three heads. One of the heads starts off at the long head, that is, it starts off at the infraglenoid tubercle. The medial head starts off at the posterior surface of the humerus below the radial groove, and the lateral one starts above the radial groove. Okay. And all three of them will converge onto a single tendon, which inserts onto the olecranon of the ulna. Okay, so it's just important to know. And a lot of times they do test for this tendon as well. Like they ask patients to keep their hands like this and they test for the tendon here. So one of the important things to know. Now the posterior arm muscles, they're innervated by the radial nerve, and again, separate branches for each head. Okay, and as I mentioned, function is to extend. Now, forearm muscles. I know this slide seems like a lot, but I'm going to break it down for you. With the forearm muscles, because there's so many, more than the insertion and origin, it's important to know their function. And what makes things even easier is that as I'm going to go over these, you're going to realize that the function is in the itself. So we're not going to complicate things. We're going to make it easy. Okay. So the anterior forearm has a superficial, intermediate, and deep layer. Now, some textbooks tend to mix this intermediate layer. They tend to classify this as superficial muscle, but again, it depends from one source to another, okay? So our superficial layer, okay, we have our pronator teres, pronates forearm. Then we have our flexor carpi radialis, this one here. It flexes and abducts the hand. The palmaris longus, again, flexes the hand. Flexor carpi ulnaris flexes and adducts the hand. So remember how our anterior arm muscles were flexing our forearm? These muscles flex our hand, okay? They flex our hand, all right? So anterior flexion, posterior extension, okay? So if you consider their position as well, you'll understand how they flex the hand, okay? Think of their position. So then we have flexor digitorum superficialis. Now, when we're talking about digitorum, when we club the fingers together, a lot of the times the thumb is not included, okay? The thumb is usually an odd one out. We have special muscles for the thumb. They're called the pollicis. So it will usually have the word pollicis, and pollicis is essentially thumb. So we have flexor digitorum superficialis, which flexes your index, middle, ring, and little fingers, essentially all your fingers except your thumb, okay? Now in our deep layer, we have our flexor digitorum profundus, which flexes the index, middle, ring, and little fingers. We have our flexor pollicis longus, which flexes your thumb. See, pollicis, thumb. Pronator quadratus, again, pronates the forearm. And you can see all these muscles here, pronator teres, and these all are quite like detailed. But what's more important for you to know is, the function, all right? Now, moving on, we have, and I also did not mention, all of the muscles of the anterior forearm, they are innervated by the median nerve, most of them, right? But anatomy, okay, there's always a catch. There's the flexor carpi ulnaris and the medial head of flexor digitorum profundus, okay? So there's the medial head of this muscle, okay, and flexor carpi ulnaris. These are innervated by the ulnar nerve, okay? And again, a lot of the times they like to pick out on these exceptions. So if you're studying for exams, learn the exceptions too, okay? Posterior forearm, all right? Now, again, it has a superficial layer, it has a deep layer, okay? Brachioradialis, it's a muscle that weakly flexes the forearm, okay? We know muscles are involved in forearm, flexion, but most of the posterior forearm muscles are extension. So this one's a bit of a odd one here, but as I said, anatomy has its exceptions, okay? So we have extensor digitorum, which extends our index, middle, and ring and little fingers. So again, digitorum, we're essentially referring to all fingers in general except the thumb. We have extensor digiti minimi. Digiti minimi, mini digit, mini digit, little finger, okay? So it extends our little finger. Extensor carpi ulnaris, extends and adducts the hand. We had flexor carpi ulnaris, now we have extensor carpi ulnaris, okay? So as I mentioned, all in the name. Extensor carpi radialis longus extends and abducts the hand. Extensor carpi radialis brevis extends and abducts the hand, okay? And there's this little muscle here that's enconeus, and that's that little muscle there, and it's responsible for extension of the forearm. You don't see this muscle being mentioned in a lot of places, but it's just nice to know, okay? We have our deep layer, which is abductor pollicis longus, that one there. which abducts the thumb. You have extensor indicis, which extends the index finger. Extensor pollicis brevis extends the thumb. Extensor pollicis longus, again, extends the thumb. Extensor pollicis extends the thumb. Supinator, I'm sure you can guess what it is. It supinates the forearm at the radial ulnar joints, okay? And again, posterior forearm, like how our posterior arm was nice and simple, just our triceps innervated by the radial, our posterior forearm is also nice and simple, innervated by the radial nerve, okay? No exceptions here, posterior, okay? So now moving on, we have our hand muscles, okay? So we have two kinds of muscles in the hand. We have our extrinsic muscles and we have our intrinsic muscles. Our extrinsic muscles are literally the muscles I just told you about, the ones that cross the wrist joint to move the hand, and they're responsible for more like your flexion, extension, and these major movements. Whereas these intrinsic muscles, they're meant to produce more fine motions and produce like a powerful grip. Like for example, if I were to hold a pen like this, I would be using my intrinsic muscles. But if I were to be moving my hand up and down like this or swirling this pen around, I'm using my extrinsic muscles. So our intrinsic muscles are divided into different groups. So we have our thenar group. And how I like to remember this is your thenar group is like TH, thumb, thenar, thumb. Okay, so your thenar group are the muscles in this region near the thumb, and they're responsible for your thumb movements. And again, as I mentioned, all of it is in the name. Flexor pollicis brevis flexes thumb. Abductor pollicis brevis, abductor pollicis, it abducts the thumb. Opponens pollicis, it opposes the thumb towards other fingers, okay? As I mentioned, very straightforward, all of it is in the name. And in case you don't know, opposition is basically this movement where you can move the thumb towards each of the fingers like that. So that's your opposition, okay? Then we have our hypothenar group. So if thenar is here, hypothenar is here, and it controls little finger movements, okay? Flexor digiti minimi brevis flexes the little finger. Abductor digiti minimi abducts the little finger. Opponens digiti minimi opposes the little finger, okay? So these are the major muscle groups, and we have other individual muscles involved as well. So we have our lumbricals, which are essentially these muscles right here. And what they do is think of their position, look at their position, okay? And imagine their function. They flex the metacarpophalangeal joints and extend the interphalangeal joints of the fingers, okay? So look at the position of the muscle. If you can't tell from the name, look at the location, you'll be able to tell the function, okay? Think of what I told you. If a muscle crosses a joint, it produces a movement. Looking at the position, you can tell what kind of a movement it produces. Carrying on with our intrinsic muscles, we have the interossei muscles. So we have the dorsal and the palmar. So we have our dorsal ones right here. And we have our palmar ones right here. And basically, these muscles, again, if you look at their position, they're pretty much located like the sides of the fingers. So our dorsal ones are responsible for abduction, whereas the palmar ones are responsible for adduction. And how I remember this is with DAB and PAD. So DAB, DAB, dorsal, abduct, PAD, palmar, adduct. Okay, then we have our adductor pollicis, which adducts a thumb. Well, our thumb's really special, so it needs its own set of special muscles. And we have palmaris brevis muscle. This is an interesting muscle compared to the other ones because this muscle, it's quite unique, so you won't be able to forget it, okay? It basically wrinkles the skin on your hypothenar eminence, and what this does is it kind of deepens the curvature of your hand. And it's important to have that bit of curvature because when you have that curvature, it basically helps you to grab onto things better because, you know, you can't have things that are completely flat. And next, we have our innervation, okay? That's important too. So again, all of the intrinsic muscles are innervated by the ulnar nerve, but the thenar group and the lateral two lumbricals, again, where is our thenar? This is our thenar, and these are our lateral two lumbricals right here, okay? Because of the location, they are innervated by the median nerve, okay? So that's basically it for your muscles. I know it seems like a lot, but honestly, if you keep reading the names, you will be familiar with all the functions. The innervation's quite straightforward. Everything's quite, easy. So now, the reason I have this slide here, our anatomical snuff box, it's not really a muscle, but it's formed of the tendons of muscles, and this has a lot of significance. Okay, the anatomical snuff box is essentially a triangular depression here found on the dorsolateral aspect of the hand proximal to the thumb. Okay, so dorsolateral, and it's proximal to the thumb. Okay, and what are the boundaries of the snuff box? We have our extensor pollicis longus. Okay, extensor pollicis longus muscle, well, the tendon actually, the extensor pollicis brevis tendon, and the abductor pollicis longus tendon. I mean, yeah, tendons, they're there. But what's more important, the floor of the snuff box, okay? The floor is made up of the scaphoid and the trapezium bones. Very, very important to know, okay? Because a lot of times the scaphoid is one of the most, commonly fractured carpal bones. So if that happens, patients usually present with tenderness in this area, and I'm sure all this will be covered in more detail in tomorrow's session. So I'm not going to go into that territory a lot, but it's just important to know. And the reason why you need to be able to identify a scaphoid fracture early is because of the structures that lie in this area. Now think about it. The radial artery goes here, okay? You also have the superficial branch of the radial nerve, which you can't really see in this diagram, but just know that it's there. And you also have the cephalic vein, okay? So it's very important to know about these structures. But what's more important is this radial artery. This radial artery supplies the scaphoid. Sometimes when the scaphoid bone gets fractured, a part of it, it kind of breaks off, and that part is compromised in terms of vascular supply. So what can happen is, if you don't identify the fracture in time, there is a risk of avascular necrosis, meaning that bone can go necrotic and die, and that can also contribute to a lot of instability in the wrist, because I said that the carpal bones fit together like a perfect puzzle piece. So it's important to know that, scaphoid fractures are of significance. Okay, so quiz time. This time we're going to go with 2 questions. Okay, so let's do our first question now. So a patient presents with the inability to abduct the fingers. Which nerve is most likely injured? What are we thinking, guys? Okay. Give it some time.
So you have 55% saying ulnar nerve and 41 saying median.
Okay, well, let's go back to our slides on our intrinsic muscles. Which muscles were responsible for abduction? These ones, our dorsal interosseous muscles. And all of them are innervated by the ulnar nerve, except the thenar and the lateral two rumbricals. So I didn't want to be too mean, so I gave you a very common one. I didn't give you an exception. So guys, it's straightforward here. The answer is ulnar nerve, okay? The dorsal interosseous are innervated by the ulnar nerve. Okay, Rishita, can we have the next question as well? Thank you.
People, 100% have said supinator.
Okay, there we go, guys. See, that's literally what I'm saying. Anatomy is that simple. It's all in the name, guys. Supinator, supination. Okay, no complications here. Yes, there are exceptions, but it's more straightforward than, exceptions. So, all right. So well done, everybody. I can see that you all are doing really well. So let's move on to our neurovasculature of the upper limb. Hopefully, this is a lot more lighter than the muscles, right? So, classic brachial plexus. You either love it, you either hate it. There's no in between. But every med student has to know this at some point. Okay, so what is it? It's basically a network of nerves that are formed from the anterior rami of the cervical spinal nerves, and the nerves involved are C5 to T1. And so it's C5, C6, C7, C8. Yes, we have 7 cervical vertebrae, but we have 8 cervical nerves. And we have spinal nerve T1. Okay. So basically, it's divided. So these are what we call our nerve roots. So C5 to T1 are our nerve roots. So C5 and C6 join together to form an upper trunk. C7 is kind of a loner, so it goes on its own, middle trunk. And C8 and T1 join together to form the lower trunk. Okay. And each trunk has an anterior and a posterior division. Okay. So roots, trunks, and divisions. Okay. And obviously, along the way, they keep giving out these important nerves, which are again of significance. But today we will focus on the nerves innervating the upper limb. Okay. So, with regards to the divisions, the anterior division of the upper trunk and the anterior division of the middle trunk join together to give us our lateral cord, while the all 3 posterior divisions join together to give the posterior cord. That is straightforward, no complications here. And this time, the our lower trunk, the anterior division of our lower trunk, is a bit of a loner, so it goes on and carries on as the medial trunk on its own. Okay, and they all join together to give us our important upper limb nerves. So we have our musculocutaneous nerve here, and it's formed as a result. And if you have a look at the roots as well, it's important to know the roots of some of these nerves. Obviously, with some of them, it's like all C5 to T1 contribute to them, but in nerves like the musculocutaneous nerve, you need to trace back and look at where these roots are contributing. For C5 is contributing here, C7 is contributing, and you basically just look at how it contributes. So our major important nerves are our axillary nerve, musculocutaneous, median, radial, and ulnar. Okay, these are the important nerves. And it's also important to note the location of the brachial plexus. So it's right there underneath the clavicle, which is also of significance because in cases of a clavicular fracture or trauma to that region, because some people tend to have very prominent clavicles and they are very prone to injury as well. So in such cases, there can be an injury to the plexus, which can cause like palsy of the nerves, which can affect the arm. But again, that's more clinical. Okay, today we're going to focus only on the anatomy. Right? So, innervation. I know this slide looks really overwhelming, but trust me, this is a summary of everything we've done so far. We have covered these ones. Accessory is a cranial nerve, and I'm sure you've tried to memorize your cranial nerves every now and then. So you will know that the accessory nerve, cranial nerve 11, it innervates the sternocleidomastoid and the trapezius muscles. You have your axillary nerve. Think of its location. It innervates the teres minor and the deltoid. Radial nerve, okay? Simple. As I said, the posterior one's very nice, very simple, okay? Muscles of the posterior arm and the forearm. That's where that's its innervation, okay? The musculocutaneous nerve, again, simple. Muscles of the anterior arm. Now your median and ulnar nerve, they're the dramatic ones. But again, we've covered all of this, so we're not going to panic, okay? So our median nerve, most of the muscles of the anterior forearm, again, except flexor carpi ulnaris and the medial half of flexor digitorum profundus, okay? Most of the muscles of the anterior arm and the 5 intrinsic muscles in the thenar half. So you have your 3 thenar muscles and your lateral 2 lumbricals, okay? So these are the muscles innervated by the median nerve. So most muscles of the anterior forearm and the thenar group and the lateral 2 lumbricals, okay? That's your median nerve innervation. Ulnar nerve, okay, it innervates these muscles here. So the stuff that median doesn't innervate, flexor carpi ulnaris, medial half, the flexor digitorum profundus, this bit here, and most intrinsic muscles of the hand. So again, all of the muscles of the hand except for your thenar group and your lateral two lumbricals. Okay, so this is a diagram again that just nicely explains the motor innervation of all of them. So you have your axillary nerve, gives you off to the deltoid, teres minor. And as I mentioned, with all these nerves, they have segmental branches as well. So they go on and supply each and every muscle. So like, for example, musculocutaneous going on to supply coracobrachialis, brachialis, and biceps brachii. Your median nerve, it has its, all of its innervations here, and so does your ulnar nerve, okay? Now, sensory innervation. I know this diagram does look a little scary, but the most important innervation to know is this part here, the hand, because as you can see, there's a very interesting fashion in which these nerves innervate. So let's start off simple, axillary nerve. So the axillary nerve, think of its location and think of, where it supplies. So it supplies the skin of the superolateral arm. So the skin overlying the deltoid and the lateral aspect of the shoulder. So that's where your axillary nerve supplies essentially, okay? You have your radial nerve. Radial nerve supplies the skin of the posterior arm, also supplies your posterior arm muscles, forearm, posterior forearm, and dorsum of the hand. So again, radial runs posterior, so naturally the sensory innervation is going to be radial, right? It also supplies the dorsum of the hand, so that bit there, and it has this very interesting fashion. It only goes up till the distal interphalangeal joints. You also have the musculocutaneous nerve, which supplies the skin of the lateral aspect of the forearm. Okay, then we have our median nerve. The median nerve supplies, again, lateral part of the palmar skin. So again, palms facing forward like this, lateral half of the palmar skin. Okay, lateral half. I know in this diagram it seems confusing, but again, keep yourselves oriented. Okay, so lateral part of the palmar skin, again, till the radial half of the ring fingers, till here. Basically, it makes up for the part that the radial nerve doesn't supply. Okay, then you have your ulnar nerve. Ulnar is nice and straightforward. Skin of the medial palmar and dorsal aspect. So this whole bit here, it's all ulnar. This bit here is median, and this bit here is radial. And honestly, that is the most important bit of sensory innervation to know. Okay, so know your sensory innervation. Now, that's our nerves done. Okay, brachial plexus covered, nerves covered. Now let's move on to our arterial supply and venous drainage. So arterial supply, very simple. Basically, in terms of, whenever we talk about arterial supply, it's essentially one big artery, okay? And then it divides into tiny, tiny branches. But at the starting, it's basically the same artery. It's just that the name changes depending on the location. So arising from the arc of the aorta, we have our subclavian arteries, okay? So it starts off as a subclavian artery there. The moment it reaches the axilla, it becomes the axillary artery. And then it goes on to become the brachial artery. And there's also a teeny tiny branch here, that's profunda brachii. That's also called our deep brachial artery. So it's like fancy names, anatomy is all about fancy names, all right? So we have our profunda brachii artery. Then we, from our brachial artery, we can see that we have a radial artery, we have an ulnar artery, and basically what happens is these arteries, they kind of meet here and form our arcs, so our superficial and deep palmar arc, and they go on, and these arcs kind of have digital arteries that individually supply the fingers and the muscle of the fingers. Okay, so yeah, again, subclavian, axillary, brachial, profunda brachii, radial, ulnar, superficial, deep palmar arc, and the digital arteries. Okay, so arterial supply, that makes sense. Okay, now we'll go on to venous drainage. Venous drainage, okay, now don't get overwhelmed by the diagram I've made here. I've tried to simplify it, but listen to me first and then we will go diagram. Okay, venous drainage is literally the reverse of arterial. You know your arterial, you know your venous. Okay, it's as simple as that. Subclavian, axillary, brachial, radial and ulnar, superficial and deep, digital. Okay, now arterial supply is when blood goes from the heart to the fingers, to the tips of the fingers. That's how blood travels. Venous drainage is in the opposite direction. So it starts from the fingers and it goes all the way back to the heart, deoxygenated blood, okay? So we're going to ignore the superficial bit because in our venous drainage, we have a superficial and a deep. For now, let's ignore the light blue. Let's only focus on the dark blue here, okay? Let's focus on the deep drainage because if you understand deep, you will understand where superficial drains into. So we start off with the deep venous arc of the palm because deep drainage, deep venous arc, okay? So the deep venous arc then drains on into the ulnar and the radius, the ulnar and the radial veins, okay? So it will go on and drain in that region, so you know, there. And then these ulnar and radial veins essentially drain into our brachial vein, okay? So they drain on into brachial vein, and then it goes on to drain into the axillary subclavian. Okay, so remember we had our brachial artery, axillary artery, subclavian artery back here. You know, subclavian, axillary, brachial, radial, and ulnar. Literally the same thing, but just reverse it, and it's veins. Okay, that's simple. What's interesting to note in the venous drainage and what's important to remember is this part here, okay? So we also have a superficial drainage, and what happens is superficial essentially drains into deep. So the superficial veins, okay, we have our superficial venous arc of the palm. So we have a basilic vein, okay, and a cephalic vein. So on the ulnar side, the vein is called a basilic vein. And on the cephalic, or the radial side, it's called the cephalic vein. Okay, so we have basilic, ulnar, and cephalic radial. And what essentially happens is that these two veins, so your basilic and your cephalic, they are interconnected by the median cubital vein. They just, you know, connect right there. And as you can see, this basilic vein, it drains into the brachial artery, as you can see. So it basilic B, basilic brachial, so it drains into the brachial. Cephalic drains into axillary. So you can see cephalic, how it travels all the way and drains directly into axillary. Okay, so I'm going to summarize real quick. Venous drainage, deep venous arc of the palm, drains into ulnar and radial veins, drains into brachial vein, drains into axillary, drains into subclavian. Superficial drainage, basilic vein drains into brachial, cephalic vein drains into axillary, both connected by the median, and axillary drains all into subclavian. So subclavian is like the ultimate, okay? Our first question, sorry.
Sorry, just give me 1 second.
Yep, fine.
I hope everyone can see it now.
Yep, we can see it.
So far we have a 50-50 between C5 and T1 and C5 to C7.
Okay, all right. So I'm glad that we have this 50-50 because I made the exact same mistake when I was a med student. I mean, I still am, but when I was initially learning about the brachial plexus as well. So basically, your musculocutaneous nerve, remember what I told you? I said, look at their nerve roots. C5 contributes to musculocutaneous, C6 contributes, and C7 contributes. C8 and T1, you don't really have their contributions involved in musculocutaneous. So yes, musculocutaneous is a nerve of the brachial plexus, but its specific nerve roots are C5 to C7, because if you look at the diagram, these are the ones that actually contribute to musculocutaneous. None of this part here contributes to it. That's why I didn't ask median, radial, or none, because if you look at median, it has complication places. Radial, it has complications from it has like its roots from so many different places. So musculocutaneous is quite straightforward in knowing that C5 to 7 is one of the nerve roots. So again, very clear question to ask. Okay, Rishta, can we have the next question?
Can I just confirm if this has been released, please?
Yes, it has.
So far, we have 66% saying axillary vein.
Okay, thank you. And 66% is correct. So as remember what I said, EB, basilic into brachial. So we're going to get brachial vein out of the way. And I noticed that a lot of people did choose, while most of you chose axillary, a few did choose brachial as well. So basilic drains into brachial and cephalic drains into axillary. Radial and subclavian, radial quite early on, subclavian is the ultimate vein, so they're not really relevant. So your answer here is cephalic drains into the axillary. Okay, so moving on to our final part. Okay, quickly, we're just going to cover a few anatomical spaces in the upper limb. An anatomical space, basically like this bit in this space created in the upper limb, and its boundaries are usually like muscles or important structures or nerves or bones or things like that. And the relevance of these spaces is the content. Okay, so first we talk about our axilla, which is essentially our armpit region. The boundaries of it are pec major, pec minor, posterior, we scapulus, teres major, lats, and the ribs and their intercostal muscles essentially form the medial boundaries. But more than the boundaries, you need to know the content. That is what's more important. Okay, the boundaries can seem very complicated at times, but it's always nice to know as well. And if you think about your anatomy, you can figure out what these boundaries are. So we look at the content. Okay, the infraclavicular part of the brachial plexus and its branches lie here. Okay, so injury to this part can also still affect the brachial plexus. We also have a couple of axillary vessels. Remember our axillary artery, axillary vein, we were discussing them. The intercostal nerves, lymph nodes, and tail of Spence, axillary tail. So it's very important in females because in females who may have breast cancer, when you're doing a breast examination, feel enlargement of this axillary tail here. So that's why this structure is very important. This location is very important. Okay. Next, we have our cubital fossa. So it's this part in the arm here. And again, triangular depression in the anterior aspect of the upper forearm, and important vessels pass through. So we have proximal, medial, lateral, boundaries. It's mainly our upper limb muscles, so pronator teres, brachioradialis, and it's essentially bisected by the tendon of biceps brachii. So, that's basically it there. And what's important about cubital fossa is its content. It has the biceps tendon, the brachial artery, median nerve, radial nerve. Okay. Sure, there's the basilic vein, median cephalic. Yeah, these veins are also important, but you also need to know that about your brachial artery and biceps tendon, because you feel it's one of the prominent tendons in the arm. If you're feeling your brachial artery, you're in the cubital fossa. So again, injury to the cubital fossa can lead to vascular compromise. It can lead to tendon injuries. So again, very important to know. We also finally have our carpal tunnel. Okay, and I'm sure a lot of you would have heard of the term carpal tunnel syndrome, covered in depth tomorrow. But your carpal tunnel is essentially a narrow passageway which is on the palmar surface of the hand, a palmar surface of the ligament and bone. A mistake that a lot of people tend to do is they assume that the carpal tunnel is at the level of the wrist, which is wrong. It's actually here, because carpal tunnel It's made up of your carpal bones. Your carpal bones are not in your wrist. Your carpal bones are slightly above there. So slightly above, like in this region, okay? The boundaries of the carpal tunnel, they're basically your carpal bones, so pisiform, triquetrum, hamate, capitate, trapezoid, trapezium, tubercle. They form like an arc there, like a tunnel kind of thing. And finally, on the top, it's covered by a sheet called the flexor retinaculum or transverse carpal ligament. This bit here, flexor retinaculum. You have like a scan here as well. Right. So why is it important to know about the transverse carpal ligament? Okay, because again, this is going to be discussed in detail tomorrow, but at times, in cases of carpal tunnel syndrome and compression, this is important to know about because it can be sometimes, used to relieve the pressure. So sometimes they can cut a bit to relieve the pressure. So it's just important. So more than that, you need to know about the flexor retinaculum. And it's also essential to know the content of the carpal tunnel. So you have 4 tendons of flexor digitorum superficialis, flexor digitorum superficialis, 4 tendons of flexor digitorum profundus, and you have 1 singular tendon of flexor pollicis. Okay, these are basically the tendons, but what's most important, more than these tendons, you have the median nerve. So it's 9 tendons and the median nerve. Okay? So if you don't remember anything else, do remember that the median nerve passes here, because in cases of carpal tunnel syndrome, the median nerve compromise, which can lead to deformities in the hand. Okay. Another important thing to remember: the ulnar nerve does not pass through the carpal tunnel. Okay. Look at where the ulnar nerve is. Look at where flexculum is. Ulnar nerve is right there, and the sheath is covering right there. So it passes through it. It passes superficially through the sheath. Okay, and which is important to remember, because if there is a carpal tunnel syndrome, it's most likely median nerve and not ulnar nerve. Ulnar has been damaged, then you'd start to consider other pathologies. Okay, so yeah, that is it, guys. I hope that makes sense to everybody. If you have any questions, drop them in the chat box, but otherwise, yeah, that's all for today, guys.
Thank you, Aisha. That was absolutely incredible, and I'm sure this is really helpful for everyone's revision. As Aisha mentioned, if you have any questions, please do put them in the chat, and I'm sure she'll be happy to answer any questions for all of you. In the meantime, I'm just going to talk about some final bits for all of you. So you'll see the feedback form, which is available in our chat right now. Don't forget to fill this out to receive your certificates and discount codes to teach me surgery and pass the MRCS. Also, be sure to complete the Google form that I have just sent in the chat for a chance to win free access to the Geeky Medics surgical flashcards and their OSCE stations. The link for all of this is available in the chat. Our next session will cover clinical conditions on the upper limb and is on the 18th at 6:30. So that is tomorrow at 6:30. We'd love for you to join us again. So make sure to follow us on our social media platforms. The links for this, again, is available in our chat. You will be able to receive updates on the upcoming sessions via these platforms. We'll also be posting SPAs on our socials for additional practice, so keep an eye out for those. Don't forget to visit our website, where you'll find a revision bank with materials not just for this session, but also for all other sessions in this teaching series. These sources include summaries and a question bank featuring extra questions that aren't available on our social media. To access this, simply create a free account on our learning portal. We hope you found today's session helpful. Thank you once again, Aisha, and all of you for joining us today, and we look forward to seeing you all at our next session tomorrow. Thank you, everyone.
Thank you.